Okay, so that's my cue to get started. So welcome everyone to our IDRPP Time to Act Substance Use Echo section. As you just heard, we are recording the echo session for educational and quality improvement purposes. And if you don't wish to be recorded, you can just disconnect from the session right now. Participation. So we are an interactive community. So we ask that you turn your cameras on, and if you're not eating lunch, and then come off mute when you have something to say, and just participate in our discussions throughout the session. We ask that you protect individual privacy by de-identifying any information you're sharing about another person. If you have any questions about like specifics with the identification, you can just reach out to a hub member, and they all should have an asterisk in front of their names. So key components of an echo session. We'll start with a didactic speaker, and today we have Savannah Eley, and she will be speaking to us about pregnancy and addiction. And then later we will have like a case presentation and recommendations. So we'll go into breakout rooms and discuss something that will be brought to us. And then throughout the session, we will just have opportunities for professional networking. So and then if you will just rename your profile with your first and last name, your state, your job title, and your organization, that will just help people identify you in chat and maybe be able to reach out to you after. If you have a question throughout the session, we will be monitoring the chat, and we will also be monitoring your guys' little icons. So you can use the raise your hand feature or just put it in the chat, however you want to ask a question. And then pre-registration, if you want to pre-register for our echo sessions, it allows you to receive materials in advance. You can do this by emailing our projectscope@usu.edu email. And then we do offer credits for attendance. The way to get one of those is you just fill out one of our surveys, which Janelle will be texting in throughout the chat throughout the session. And then we use Canvas to store all of our materials. So if you want to be registered for our Canvas page, once again, just email projectscope@usu.edu, and then we will get you signed up for that. And then we always have case studies at the end of our sessions. So anyone's welcome to send in a case study, and either we can present it for you or you can present it yourself. And it's just a great opportunity to just receive feedback or recommendations if you're struggling with a specific case. And then we're excited to announce our 2025 network. It is now opened up for you guys to register. So we will be moving to a new platform called iEcho. If any of you attend our other echo sessions, that's where we are hosting them now. And so we're just transitioning onto that. Right here, we just have the steps for you to register for that. And then we'll be sending out an email with more specifics. But yeah, if you just scan this code, you can register for our network next year. And then we do have our social media pages, our Facebook, our Instagram, and our LinkedIn. So follow us and you can receive updates on upcoming sessions or just previous material. And then we also created a new Facebook group. So this kind of allows us to continue discussions after sessions. Once again, receive updates on upcoming sessions, and then just continues our professional networking opportunities. So if you're interested in like continuing discussions after sessions, you can sign up for our Facebook group and continue to network. So perfect. So I'm just gonna stop sharing, and then I'm going to share Savannah's slides, and then we can get started with our presentation.
Hello, everyone. I am Savannah Eley. I will be presenting today on pregnancy and substance use disorder. So the topic I will be talking today about is substance use disorder and pregnancy, postpartum, and what we can do to help, right? Like, what are if you want to just go to the next slide. So I do not make any financial gains or anything from anything that I am saying. And I am not an expert in pregnancy stabilization or addiction medicine or anything like that. So you want to go to the next slide too. So what do you think the biggest risk factors are for someone who's pregnant that could possibly suffer from substance use? Obviously, past use, a history of past use, unintended pregnancy would be one of them, lower level education, unemployment, mental health disorders, childhood trauma, environmental stress, domestic violence. Are there any other ones that people might think of that might contribute to someone being using while they are pregnant? Family history use, yes, generational. That's the one that a big one that we actually see here at Castle View Hospital is family use. Generational substance use is huge. We see it all the time. A lot of times when we have women that come into the hospital that have delivered a baby that is dependent on the substance, right? Because a baby cannot be born addicted to a substance, but they can be born dependent to the substance. There's two different things. Addiction and dependency are two different things. A lot of times, when you sit down and you talk with them, family history, a lot of generational substance use. So that is a huge one. Childhood trauma is a big one too. And someone who didn't intend to get pregnant at a younger age. If you want to go to the next slide, please.
There we go.
So this is from the University of Utah, physical and mental problems. Yes, that is a huge one too. That is a big one. So this is a self-reporting opioid use during pregnancy. So I'm sure that everybody here might be familiar with the Super Rad program, which is at the University of Utah. Dr. Marcella is one of my favorite people. I call her and pick her brain all the time on this. So this is self-reporting opioid use per 1,000 pregnancies, 1999 to 2014. State, as you can see, our state would be the red, national is the blue. We are growing, since from 2010 to 2017, I think the increase of opioid use during pregnancy has increased 131%. So that is a big, huge increase. And most of the time when, they're using opioids, there's polysubstance use involved. They're using more than one substance. But just to see this trending up, and this only is, we all know that data is slow. So just from this being to 2014, it makes you wonder when they come out with the next, what that will look like. But this is just a state inpatient database. So yeah, that's a huge trend. If you could go to the next one, please. So obviously, opioid use disorder during pregnancies has been linked to an increase in very negative side effects, such as preterm birth, stillbirth, maternal morbidity, I can't even say that word right now, and NOWs. It's dramatically increased in maternal opioid use and neonatal abstinence syndrome. Every 25 minutes, a baby is born suffering from opioid withdrawals. Average length or cost of hospital stay, as you can see for the withdrawals. It's hard to see that little thing, but this is huge. We see this a lot. We see a lot of women who come in who have had no prenatal care whatsoever, come in labor and deliver a baby. And, we're having to transfer the baby out sometimes. You know, it's increasing. Like this is not something that's talked about a lot, and I think it's because of stigma. But substance use and pregnancy has is increasing. It's like out of, it's out of control. It's increasing. So you can go to the next one. As you can see, pregnancy related deaths data. So maternal deaths per 1,000 live births, 24.9 maternal deaths per 1,000 births. 84% of those were preventable. Substance abuse disorder and mental health contribute to 25 and 26 of pregnancy related deaths. As you can see on the graph, this is a national average in the United States from 1987, or what am I looking at? I can't even see it. Clear up to 2020. I mean, it is skyrocketed. And at what point do you feel like, and I'm gonna ask, is the highest point the biggest risk for someone who is recently, who has had a baby? When is the highest risk for their death? Does anybody know? Or if they was to, if they was to die after having mom, but you can go to the next slide. 3 months after. Drug-induced deaths are the leading cause of death for reproductive age women in the United States. Utah from 2005 to 2014, the majority of drug-induced deaths were attributed to opioids, prescription opioids, and polysubstance use. Drug-induced deaths was the leading cause of pregnancy-associated deaths, and 89% occurred in the postpartum period. So the postpartum period is the highest risk for a woman who has had a substance use disorder, suffered a substance use disorder. Maybe she's in recovery and, she's doing well and had the baby. The postpartum period is the most, it's the most dangerous time for somebody to overdose. If you want to go to the next slide, please. So what causes pregnant people to not seek treatment? We'll just start from this one. Stigma, fear of judgment, barriers to care, fear of DCFS involvement, lack of resources, especially in rural areas, lack of medication for opioid use disorder treatment, especially in rural areas, no transportational for prenatal care. Is there any other things that you can think of that might cause someone who is pregnant and suffering from a substance use disorder to not seek treatment? Or not talk? Maybe they're seeing an OB, but they are not talking to their OB about that they're using opioids. I would say yes. In Alabama, it is a felony to use. Lack of education that is needed, yes, absolutely. Not having the right information and support, yes. Embarrassment, absolutely. That is number one too. Shame and guilt and embarrassment. I think the shame and the embarrassment, obviously, is one of the reasons why women do not seek treatment when pregnant. I think that's, a lot to do with it. Stigma, fear of judgment. Alabama, it's a felony. That would definitely play a huge role in it. A lot of times when I meet with moms who have just had babies that are dependent on substances, and I ask them, why didn't you get any prenatal care? Their biggest thing is I didn't know how. Like I didn't know how to, I didn't know how to bring it up. I didn't know how to bring up the conversation with my doctor. I was too ashamed. I didn't want him to know. I didn't want my baby to be taken away. I was hoping to be able to come off of myself, and that's true. 85% of women can taper themselves off of opioids. It's the 25% that can't, right? That we need to have resources available for. If you want to switch, go to the next slide. Yes, they don't accept or realize that it is a problem. Yeah. Especially in Utah, if you have a prescription, it's not a problem. Just kidding. So, medication for opioid use disorder treatment in pregnancy. Treatment is a crucial during pregnancy because it significantly reduces the risk of adverse pregnancy and maternal outcomes for women with opioid use disorder, including the risk of premature labor, stillbirth, and NAUS in newborns, while also improving overall health and stability for both mother and baby for preventing withdrawal symptoms and minimizing relapse potential. Especially, sorry, you guys, I don't have my glasses on. So it is a preferred method of managing OUD during pregnancy compared to attempting withdrawal without medication. So here at Castleview, what we're trying to do is build, you can go to the next slide. So as you can see, this is Utah. So the dark blues are the high risk zones for opioid. They're the leading causes of, opioid overdose deaths. And these red dots over here are treatment, medication, med management, pretty much medication for opioid use disorder. Those little red dots, as you can see, there's so many that it's just dispersed, right? But you can't walk into every place and be like, oh, here I'm pregnant and I want to be placed on Suboxone, because the doctors fear that. OBs fear that. OBs don't want to use meds. I'm not talking for all of them, but I'm talking for some of them. I've talked to OBs before that say, I don't want those type of women in my clinic, when they don't realize they're already seeing those type of women. They just don't realize it until after she gives birth, right? But Utah is so rural, like the rural parts are getting left behind. So the STAR is super rad, which is located at the University of Utah Hospital. It is a pregnancy stabilization for women who use, or pregnant people who use opioids or any other substance, where they can go in and get stabilized on medications, and go to treatment. They set them up. Anybody can utilize that. What's the hard thing is trying to get an OB on board after they leave that will continue that medication. So 90% of the resources here in Utah for opioid use disorder in pregnancy is located in the Wasatch Front in Salt Lake. That STAR is super rad. They're about the only ones right now that are doing any sort of stabilization for pregnant people. So it's kind of sad to look at all that and see that, especially in Tri-County, there's 3 places where you can get medication for opioid use disorder. I think it's gaining more. I think now that the X waiver's gone, I think doctors are more willing to prescribe it, but there's still so many doctors that are stuck in the way of it's replacing one for another, and we can't do that. I don't want to do that. So the X waiver was a waiver that doctors had to do and go. It was a waiver that the doctors had to, it was a course that a doctor would have to take to be able to prescribe Suboxone. So since the X waiver has been gone, you no longer need to take this, 24-hour course or however long it was. Any doctor can prescribe Suboxone. I still think that talking with doctors. Some of them do not want to prescribe them. Some of them will not they will not prescribe Suboxone. They feel like it's trading one for another. If you would like to flip to the next slide, please. Postpartum. The postpartum period is the critical period for women with substance use disorder. For postpartum women struggling with substance use disorder, the demands of a newborn, loss of continued with trust provider, loss of insurance, increased risk of postpartum depression and anxiety and sleep deprived may result in the perfect storm, leading to drug use, relapse, overdose, and death. I can tell you firsthand, as someone who is in recovery, it was always my perfect storm. I would get sober when I was pregnant. And as soon as I was done having, I'd have my baby, it'd be the perfect storm for me. Blood pressure, and sleepless nights, postpartum depression is actually what started my my journey through addiction. And it seemed to be for me that every time I would get sober during a pregnancy, and then that first prescription that I left with, it would start right back from there. And so postpartum is really a scary time for pregnant women or someone who suffers from substance use disorder, even someone who is on MOUD treatment and has the medication for opioid use disorder. Postpartum still is a critical time for them too. If you would like to go to the next slide. 43 to 365 days after the end of pregnancy, timing of pregnancy related deaths in Utah from 2015 to 2020, 53.1%. That's 34 pregnancies. That is terrible, and that is the time frame that is the most dangerous. It's not 6 months after, it's not 30 days after. It can be up to a year after someone has the baby, that they are high risk for overdose related deaths. As you can see, during the pregnancy or delivery, it's 21.9. 1 to 42 days after the end of pregnancy is 25%, but 53% of it is 43 to 365 days after the end of pregnancy. That is a high number. If you'd like to go to the next slide, please. Okay, so SUD and maternal care postpartum. For SUDs highest in late postpartum, drug-induced deaths are the leading cause of deaths for reproductive age women in the United States. Utah from 2005 to 2014, drug-induced deaths was the leading cause of pregnancy-associated deaths. And 89% occurred in the postpartum period. Most specifically, those with a drug-induced death were more likely to die in late postpartum period, defined as death occurring within 43 days to a year of the end of the pregnancy, compared with women whose deaths were from other pregnancy associated causes. So that later part, that 43 days to a year, that's really a critical time for someone who is high risk. You can go to if you want to go to the next slide. And if anybody has questions, please stop me. So what is the way to handle is medication assisted treatment. The postpartum period is critical period for women with substance use disorder, a time of increased vulnerability, and women with opioid use disorder relapse far more often in the postpartum period compared with during pregnancy. So that is the perfect storm, right? They have so much pressure from being a brand new mom, not getting enough sleep. There's so many different factors that play into it. It is the perfect storm, but it is far more often in the postpartum period compared to during pregnancy. Usually, sorry. Did
I
someone
just,
say something?
yeah, I just have a question, Savannah. So is it a higher risk of death postpartum because they've also had if they've had their child taken away, or is it just the ones that keep their children? Like, is there any statistics of that?
No, I didn't see any statistics of that. Usually here in Utah, how it works is if I didn't see any statistics on that, and I looked for that because I wanted to see like what were the statistics of like were these women who had their kids or were these women who didn't have their kids? Um, but I can say that I don't know if you guys are familiar with the Super Rad Clinic with Marcella Smith, but after a mom loses her baby, the risk of her relapsing is so much higher than um, well, not that she relapsed, but having her baby taken away, her chances of ever coming out and getting sober are very slim, I should say. A lot of times they'll fight for them, but sometimes they're defeated. And that's why like getting them while they're pregnant and getting them on MOUD treatment, stabilizing them, engaging them in treatment during the pregnancy is so important. That's why with us at Castleview, we're trying to build pregnancy stabilization, right? Sorry, I'm trying to read comments too. What about women who have a problem with meth? Are there good treatments for them too? There actually are. We can actually bring them in and stabilize them off of meth too. A lot of times, heroin and meth go hand in hand, right? It's done together. It's not just I shouldn't say every time, but some women just use meth, and there are options for women who are using amphetamines, and they can come in and stabilize too. Um, and there's medications that they can use to help them with the cravings on that. Obviously, there's nothing that has been approved by the FDA for meth use. It's kind of just let's try something. Opioids, they have a lot of medications that they can use. Meth is just not like that. I wish it was. Um, so it's kind of just like you wing that. I shouldn't say wing it, but you get them in, you stabilize them, get them into treatment, get them, you never fix it until you get to the root of it, right? So trying to get to the root of it is super hard and very difficult, but getting them while they are pregnant is the most important. If you would go to the next slide, please. Okay. I guess I mean I've told you these are a lot of the reasons why um women are at higher risk at the end of postpartum than they are during pregnancy is the majority of maternal deaths occur postpartum. Yet traditionally only one visit at 6 weeks an entire year postpartum. Needs new provider, SUD, behavioral health medicine, not the new doctor might not prescribe the medicine that or their OB might not prescribe them Suboxone. He might not believe in it. And Medicaid coverage ends, or they never even had it. I know, warm handoff from an OB to a new doctor that can prescribe Suboxone, peer support, behavioral health, like that whole continuum of care needs to happen with these high risk patients. And it's not happening. A lot of the times, what we see is just, people not wanting to deal with these type of people is what they say. We do have one great OB. We have a couple, well, I shouldn't say one. We have a couple great OB GYNs that are taking care of women now, and they'll get them involved with treatment and not just like, the medication for opioid use disorder, Suboxone, methadone, whichever one they choose. But also behavioral health treatment, peer support. They have so many different options now. Can you go to the next slide? I think it talks more about that. So what can we do, right? Educate providers on the importance of MOUD and OB, on a warm handoff to a new provider of MOUD and BH treatment, behavioral health treatment, advocate against stigma and the treatment of substance use. A lot of people don't want to treat substance use. They think that, using Suboxone is just trading one for another, and it's not. And even if it was, at least we know what they're taking, right? At least we know that it doesn't have fentanyl in it, that they're not going to go out and die, because once they're dead, we can't save them. And be the change, scream for the change. If you see a barrier, work with your community to provide a solution. Get peer support involved. Someone with lived experience is very critical. Like, you can't, peer support is huge. They have the lived experience that most people need. They can relate. They have the empathy, and they also are, sober, and they can help them through. There's a new thing that Utah's doing, and it's called recovery doulas, and it is um, peer support or recovery coaches that are going and being trained to do recovery doulas, be a recovery doula for women who use substances pregnant. So get peer support involved, and so no one falls through the cracks, and that should be from the get-go, right? Because so many people fall through the cracks because there are so many cracks that people can fall through, but if we're holding on to them, they're not going to fall. Can you go to the next slide, please? This is my reference page and my resource page. There are resources here. Some of these will, have protocols on them. Some of these don't. They do have a set of protocols for how to handle it in a hospital setting, how an OB can initiate Suboxone. I think that the louder, how do we, as early childhood, support the mothers? That's a good question. I'm just trying to sit back and think from my point of view, like, how could you support the mothers? I guess just be there, non-judgmentally showing up for somebody. I was one of these people that could have used a program like this. And so now I see this in my community, and I see that my community needs this, and now I'm going to build it. And I think showing up for the mom, helping her, it's overwhelming. I mean, even for someone who's never struggled with substance use or depression to have a new baby, it is overwhelming. So showing up for her, asking her, do you need help? Do you need me to maybe take the kids and, you can take a nap, or, do you swing by and drop off dinner? Watch for risk signs, talk to her about how high risk, if that maybe she did suffer from a substance use disorder prior to this delivery, having a new baby. Talk to her about how high the risks are, postpartum. And, if she wants help and she needs someone to advocate for them. If she's pregnant, advocate for them, take her to someone who can initiate Suboxone, get her on Suboxone, methadone, whichever one they choose. It's a lot safer than what they're using on the streets. The safest way is Super Rad. The Super Rad clinic is great at doing that. They're great at helping if people have questions. They're great at helping you, come up with a solution for your community. I've worked with Marcella Smith for many, many years, and she's actually the one that founded Super Rad. And we're hopeful. We're hopeful with Evergreen Healthcare that we can that we can take this throughout, not just Utah, but through other detoxes that we have in hospitals and offer at pregnancy stabilization. And yeah, there are peer supports throughout the state of Utah. USAR is a great USAR is great. Usually they have peer support at behavioral health centers. They'll have peer supports there, like, Four Corners Behavioral Health or Southwest Behavioral Health. They have peer supports there that they can see in case management. Any resource that you have that you feel like would benefit this person, I would hook them up, even if it was case management and peer support. I mean, you can't have too many resources when the rates of dying postpartum are so high. Do you want to go to the next one? Any questions? That was fast. Sorry. Are there any questions?
I know you mentioned that like these women often face a lot of stigma due to like substance use disorder. Do you have like any like things that we should or like shouldn't say so they feel like they're not being judged when supporting them?
I definitely meet them where they're at. If they don't want treatment, they don't want treatment. Meeting someone where they're at is huge, right? If they're asking for treatment, be there for them. Don't ever refer to them as their babies as addicted. When a baby is born from a mom who has had a substance use disorder, it is a dependent on a substance, right? Addiction, it's not addicted to it, it's dependent. But if you have somebody that you're helping, let's say you have a mom and you obviously know that she's struggling, talk to her. Just say, hey, I take her aside, do it in, not in front of anybody, but just say, hey, I can see that you're struggling. Is there anything I could do to help you? There's all these resources available. I just want to make sure that you know about them, like educate them. Education's the biggest thing. I think the lack of education around substance use and pregnancy is a huge barrier for most. Most women don't know what resources are out there for them. When they're pregnant and they're struggling. We get a lot of calls here and we try to handle them accordingly. If I feel like it's too, we're not set up here yet to do pregnancy stabilization, but I work very closely with the OBs and we've done it. If I feel like maybe the best option for her would be going to Super Rad and getting stabilized on medication and then maybe going to House of Hope and getting some treatment, right? I know a lot of times people fear DCFS. So if there's other kids that a mom has, that's you have to report on that if you see that. And so it gets tricky. Most just come. If I could say the most valuable thing would be come with compassion and empathy and put yourself in her shoes. Because it's not that she doesn't love her baby that she's carrying or she doesn't love her kids. For me, I can speak on this. I love my kids more than anything. I struggled. I had a disease. I've had 8 years sober now, and my kids are my top priority. They always were. I just was sick, and I didn't realize how sick I was until about 3 years into sobriety. And I could look back and say, wow, I was really sick, but the more time we have underneath of us, the more healing that happens and the more we learn. One thing I can say is when I got sober, there wasn't a recovery meeting here. And so I thought, I'm going to be the one that builds this. I'm going to start something here, and since then, that's all I've done is build things. Thank you. And we just got to come when we approach someone with a substance use, they might be defensive, and that's okay. Let them be defensive, but you're going to plant that seed of hope, because when I was approached about my substance use disorder, I was very defensive. I didn't want anybody to know, but it planted a seed. And once that seed plants, right, it might just take a little while, but it grows. What is it about the medication that can be used in place for illegal drugs that some doctors feel is not a good replacement method? I would say a lot of doctors, they don't want to use Suboxone or methadone. I can't speak for all doctors, but I know that some doctors feel like it's trading one for another, because obviously you become dependent on a Suboxone, and methadone's a full opioid antagonist. And so they don't like doing that. But you know, the one great thing about it is now they have the Sublocade shot. Pregnant women can have the Sublocade shot. So if you can just initiate the Suboxone, then, you know, you're setting her up for a Sublocade shot, which it would be very helpful. But what about women that have, you know, I've heard of people treating them with, you know, and this is just in the treatment field, with Wellbutrin and naltrexone combined, for meth use. I see that that's how, I mean, Wellbutrin is a stimulant. Naltrexone helps the cravings. It doesn't work for everybody. I seen doctors put people on Adderall for that. It's harm reduction. At least you know what they're taking, right? That's how I feel about a lot of things, is at least we know what they're taking, because when you're buying something off the street, you don't know what you're taking anymore. But for meth, I see a lot of Wellbutrin and naltrexone used together in combination for meth use.
There was also a question a little bit earlier in the chat that said, does DCFS help the mom seek treatment?
Gosh. You know, if you are, it depends. It depends on what state you live in. Like Utah, if Utah, if you are, say a mom comes in and she has a baby that is born dependent to a substance, usually what happens is they don't keep the baby, right? The baby goes into the system, the mom has to prove herself. You know, she has to really work hard. And I've seen this go two ways, right? I've seen that happen where they've had a warrant for the baby. And then I've also seen it happen to where the mom was on Suboxone, engaging in treatment, was open with her OB, and you know, DCFS wasn't even called. Here in Utah, if you are working on your opioid use disorder or whatever substance use disorder, you know, alcohol, marijuana, Adderall, meth, if you're working towards that with your provider, with your OB, and they know that you're on this medication and that you're doing treatment and that you're doing well, they're not going to call DCFS. It shows that you're improving, right? Now I can't say not all of them will, but the ones that I've talked to and dealt with, they don't. Social workers won't. As long as you're engaging in treatment and you're moving forward, they're not going to. But what they will do is they will educate you, hopefully, on you know, put the postpartum period and how high risk you are, you know, at the 43 to 365 day mark, and give them a warm handoff to a provider that can continue that medication for them, or even the Sublocade shot, and offer the Sublocade shot again. You know, Sublocade, I feel like, is a pretty good product, for, you know, especially a new mom. It's hard to get to the doctor. You don't, you know, so, and I think just getting her involved in, you know, therapy is huge, especially in that new mom phase. It's hard. And you know, maybe she does have childhood trauma and maybe it's perfect for her to, you know, work through. That's, you know, we don't know. We just need to ask them what they need. What can we do to help? And we need to just make sure that we're not letting people fall through the cracks, especially this high risk of an individual. See, I'm wondering about women who also have marijuana or Adderall addiction. Do you know if there's treatment for them as well? They can socially detox off of the marijuana. Adderall, I would say the best way would be to call Super Ad and see if they could just taper them off of it. You know, meth is just a totally different drug than an opioid because of the dopamine and that it releases compared to, you know, an actual opioid versus meth. Meth releases so much more dopamine than heroin does. So it's super, you know, super hard to stay off of, I should say. But I would definitely talk to a social detox. Casey, I'm hope I'm pronouncing your name right. I'm not sure where you're from. But I know here in Utah we have social detoxes where we can send people, they can stay for up to a week and they'll take people who use marijuana, pregnant women who use marijuana, Adderall. I know when I was building it for Four Corners, we built a pregnancy stabilization piece for them too. Just a lower level, you know, care. It just depends on what trimester they're into. So Davis Behavioral Health, Southwest Behavioral Health, they all have Wasatch. Like the crisis receiving centers also do social detox. They should be able to help. They pregnancy test everyone that comes in. So if you have somebody that is, you know, needing to detox from Adderall or marijuana, I would say a social detox would be the best place for them. Social and at one of those locations. And I'm pretty sure every crisis receiving center now is doing social detox. And a lot of times I know the one here in Carbon, it is fully funded, so it doesn't matter if you have insurance or if you don't have insurance, they will take you. You know, and then they have case managers that help set everything up. You know, get them into treatment if they want to do treatment inpatient, or, you know, get them set up with some sort of treatment with inside their facility. Any other questions? You're welcome. I think you can go to the next slide too. I think it has my contact information on it if anybody-
Awesome. So I'm just gonna leave a little bit more time for questions as I switch our screens. So if you guys have anything else to say, just put it in chat or come off mute. And then, yeah.
I just want to tell you all, thank you guys for listening. I know this is a taboo subject, but it is a real epidemic. And it is something that, as you can see, there's not a lot of treatment options for people who are struggling with substance use during pregnancy in the state. It is really hard for these women to even, most of them don't have a ride to somewhere, and trying to get from Salt Lake to San Juan, you know, that might be hard from them, or from, you know, Cedar City to Salt Lake to do Super Rad is really hard on them. The more resources that we can have for pregnant women or pregnant people who are struggling with substance use disorder, the more compassion that we can wrap around those moms after they deliver, the better off their life's going to be. And, you know, it might just be the ending of that generational curse, right? Breaking the cycle. And we all have to start breaking the cycle somewhere. And this is my passion. I love this. And I just want to tell you guys, thank you so much.
Savannah, thank you. And I really appreciated also the fact that you got us all thinking about just kind of reframing our mind or our thought process about it. And I think that's it seems like would be a really helpful thing for us as the community to do. That the child's not born addicted, that they are dependent, that the mom there's reasons why this is happening and how do we help support them. So I think that that's a critical education piece as well. And thank you for sharing that with us.
You're welcome. Thank you guys for letting me.
Yeah, thank you so much. I think we're ready to move on to the case presentation. So awesome. So today we just have a practice case presentation and background. Lisa is a 28-year-old woman who is in her second trimester of pregnancy. She has struggled with opioid addiction for several years following a back injury that led to a prescription for pain medication. When her prescriptions ran out, she began using heroin to manage withdrawal symptoms, and she recently sought help at a local clinic in Vernal, Utah, after discovering her pregnancy. She wants to ensure the health of her baby, but is overwhelmed by the physical and emotional challenges of the withdrawal, as well as the stigma she experiences from her family and her community. She has limited financial resources and unstable housing, which complicates her ability to access consistent care. Okay, so the primary area of concern in her case is the impact of her opioid use on both her health and the health of her unborn baby. Prolonged opioid use during pregnancy, as we talked about, can lead to neonatal abstinence syndrome, preterm labor, and other complications. Additionally, her lack of access to stable housing and prenatal care poses significant risks to both her and her baby. Addressing her addiction while ensuring she receives adequate prenatal care is critical. So some of the goals are to support her in achieving and maintaining sobriety through medically assisted treatment and counseling, ensure that she receives regular prenatal care to monitor her health and the baby's development, provide stable housing and access to social support systems for her, and then educate her about parenting skills and prepare her for the challenges of motherhood. And then her barriers include her financial instability, stigma and judgment from her family, limited availability of specialized programs for pregnant women with substance use disorders in the area, and then her fear of legal consequences or losing custody of her child if she discloses her addiction. So for our community discussion, we have the first question will be, what types of resources and services could the community offer to support Lisa in overcoming her addiction and ensuring a healthy pregnancy? Then how can healthcare providers address the stigma she faces and create a non-judgmental environment for her care? And then lastly, what role can housing programs and financial assistance play in stabilizing her situation? So Janelle, could you drop the groups into the chat?
Yeah, and then Kurt is wondering, did you say this is her first child?
Yeah. Awesome. So we have a little bit of time left, so we could just have each group share something, and then we can just start with Lisa. Want to share something you guys talked about?
Sure. So the question that our group talked about specifically was, what types of resources and services could the community offer to support Lisa in overcoming her addiction and ensuring a healthy pregnancy? And we had a hard time thinking of resources that would be local or in the rural area up in Vernal, but there were 3 resources that were mentioned down in the Salt Lake area that would be or could be potential options. They were the Odyssey House or the House of Hope. Both, the thought is she would need to spend or could potentially spend a few months at one or the other when she's pregnant, and that may potentially decrease the risk if she could get off of being substance dependent, as well as learn parenting skills, maybe decrease the risk of losing her child when the baby's born, or losing the baby when the baby's born. Another suggestion was, it's called the Super Rad Clinic, and I had not yet heard of that one, but it sounds amazing. It's at the university, or out of the University of Utah. But one of the suggestions was, could a local physician who she sees in Vernal maybe reach out to the clinic to see if they could partner and provide her with the supports or the treatment that would be beneficial to her without her relocating to Salt Lake through that clinic. So that was an option as well that I thought was a really great suggestion.
Perfect. Can we have Kurt or Tony, whichever of you want to share something?
Did you want me to share, Kurt, since I took the note? I got the thumbs up. We had a really good discussion. Our question was just talking about destigmatizing for like healthcare workers, destigmatizing that around her situation. So just a few of the things that we talked about were that just remembering that addiction is a chronic brain disease, and that sometimes it's hard to just stop. There's more involved than that. Some of the things that were said that I really liked, not judging, because judgment just keeps you using. Also, education for providers is really important, having empathy and compassion. And then something we talked about a lot was keeping in mind what's best for the patient and making sure that we're not letting our own personal belief systems get in the way of providing what really needs to happen for that person. So keep our own personal feelings out of it and make the focus really to be getting resources out for that patient. So we had some really good suggestions in our group.
Thank you all so much, and thanks for sharing. Whoever took notes in the groups can just send the resources to projectscope@usu.edu. And yeah, our next session will be January 8th. And like I said before, we'll be on iEcho, and we'll send out more information on how to sign up. But yeah, and then you can also check our website. We have the link on there, so perfect.